We have Alan Haynesworth, who's a credentialed mental health nurse in community mental health, both in Australia and in the UK. He has been responsible for commissioning supported housing schemes, and he is also a proficient ukulele player. Dr. John Farhall is a clinical psychologist and senior lecturer at the School of Psychological Medicine Science at La Trobe University, and he's a consultant clinical psychologist for the Northwestern Mental Health Service in Melbourne. He has 30 years' experience in mental health. He has specialized in psychotic disorders, particularly in the use of therapies including CBT, ACT, and behavioral family therapy in psychosis. He has been a chief investigator of randomized controlled trials of both CBT and ACT for people with psychosis. And lastly, we have Professor Alan Rosen. Alan Rosen is a senior consultant psychiatrist and a professorial fellow, a senior consultant psychiatrist at the School of Public Health, Faculty of Health and Behavioral Sciences, University of Wollongong. He has held many senior positions both in mental health services and in academia. He has spoken extensively and visited as a specialist Europe, the United States, and Asia. He is the author and co-author of many papers, particularly concentrating on psychosis and the roles of inpatient care, rehabilitation and recovery, acute and long-term inpatient care, early intervention in psychosis, stigma, dual disorders, deinstitutionalization, and many other interventions. He's the recipient of many awards in recognition of his significant contribution to mental health treatment and care. Tonight, the webinar will take the form of presentations from the three panelists. You would have all read, as part of your preparation, the case of Mark, a 49-year-old man with a 30-year history of psychosis, and Alan Haynesworth will go through his history and present him. This webinar is hosted by MHPN, as I said earlier. It's a Commonwealth-funded project. It currently supports 480 local interdisciplinary mental health networks. Tonight we have over 200 people attending this webinar. I would like to thank you all for attending and to apologize just for a minor glitch at the beginning there, a minor technical glitch. We have learning objectives for tonight. At the end of the session, the participants will recognize the phases of illness and disability requiring specific interventions and care in psychotic disorders. They will recognize the common core principles of effective mental health treatment of psychotic disorders, and they will recognize the challenges and opportunities in providing integrated and holistic mental health services for people experiencing psychotic disorders. If you wish to find out more about your discipline's CPD recognition, visit the website. Now, the rules tonight are that you can ask questions by typing into the box at the bottom of the screen on the right-hand side. I will keep an eye on the questions that are proffered, and we will take a representative sample of questions. Each presenter will present for 8 to 10 minutes, starting with Alan Haynesworth, then going to John Farhall, and then to Professor Alan Rosen. There will then be a panel discussion, and I will then be prompting the panelists during the discussion to ask questions of each other, just to get the panel discussing the case. We do look forward to your questions and value them. At the end, the panel will each take 2 minutes to reflect and to sum up on the evening, and then I will sum up at the end. Please ensure your sound is on and your volume is turned up. Remember that webinar recording and PowerPoint slides will be posted later on within 24 hours on the MHPN website. Please remember to submit your questions in that box in the bottom right-hand corner. We'll shortly be asking Alan Haynesworth to start his presentation. This is an extremely interesting case, as I'm sure you'll all agree. Very common case that we all meet in clinical practice, and it's just really good to have 3 experts on our panel tonight, people who are used to working with patients with psychosis, and I'm sure they will be pleased to answer your questions. Now, I'd just like to hand over to Alan Haynesworth now.
Well, I'd like to thank everybody for watching the video of Mark that was posted and reading his fascinating story. And I'd like to thank Mark as well for allowing us to share his story tonight for educational purposes. Work with patients, of course. We share their despair as well as their hope and their achievements, usually against all odds. Mental health nursing has to be the best job in the world for anyone who is interested in people, the diversity of humanity and social justice, as I am. I think this case, though, is a bit of a classic in that Mark was my first exploring illness in the primary care sector. I'm soon moving from about 20 years of hard labour in the secondary care sector. And the first big different approach I noticed was getting to assess a new patient on my own, as opposed to either in pairs or even as a threesome with the omnipresent security guard as chaperone. The other big change for me was not relying on a detailed written history and mandatory risk assessment before I started. So it was more about the here and now and the future. It was more positive, and I liked this approach. One of nursing's most dynamic shapeshifters and great hero of mine, Hildegard Peplau, what a great name, in 1962 described the heart of psychiatric nursing as the role of counsellor or psychotherapist. Other functions such as mother surrogate, technician, manager, socialising agent, and health teacher she listed as sub-roles. Hildy, as I like to know her, believed it was using the patient's positive feelings toward the therapist that brought about psychophysiological homeostasis. So it's very humanistic and far from being rocket science either. Much of the rhetoric has changed over the years, but the essence of the job remains the same. And old Hildy will be proud to see the progress being made by mental health nurses on the wards and in the community, out there specialising and leading the way in all sorts of essential areas, including CBT, family therapy, narrative therapy, motivational therapy, etc., etc. A far cry from the image portrayed by Nurse Ratchet in One Flew Over the Cuckoo's Nest, a cold, sadistic, passive-aggressive tyrant, responsible, remember, for having McMurphy lobotomized. That novel was also written in 1962, interestingly. So just like the Beatles, Hildegard was ahead of her time, and Love Me Do reached #1 in that year. So we'll go on to the symptom picture for Mark, and we've got a slide up here which includes, there's a whole massive array of symptoms for Mark, including delusions, hallucinations, thought disorder, and certainly a terrible disorganization of his thoughts, chaotic and disorganized lifestyle, occasionally angry and irritable, disheveled and unkempt, alcohol problem, financial problems. So we're on to the next slide now. Social isolation, housing problems, dental neglect, the risk of a possible sexually transmitted disease, and non-compliance. This combination of features, and it's longer than that, that's a short version, remind me very much of the diagnosis of hebephrenic schizophrenia or too hard basket schizophrenia. It's a term that we don't use much, but whenever I have a patient like Mark, I look up this old diagnosis and think, yes, that's it, spot on. The last point, which is non-compliance, is very interesting and particularly relevant in that how Mark was able to progress so much under previously being labelled non-compliant. This term is common for people who are being treated for psychosis, as they tend not to like the medication they're prescribed for reasons like weight gain, impotence, lethargy, stigma, etc. I think Mark described it to me once as, having tried it in the past, as stultifying. Now, as much as I would have pre-medication, I knew he was definitely hostile to this idea, and I was aware that any chance of recovery would have to be in a non-coercive environment where sensitive use of language a prerequisite. I believe Mark enjoyed having the freedom to make poor choices. It's a privilege that is often denied to people suffering mental health problems. Sadly, often the professional view is that the best they could hope for is to be well maintained through medication. And so strong is this belief that much of the work mental health professionals get caught up in close collaboration with the police guards, is coercive, evasion, threatening and restraining in order to prevent the relapse. So back to Mark and his symptoms. Where do you start with a list like that? A total catastrophe, a life of persecution, social disadvantage and loneliness. But hey, hang on, what about the strengths? Now here's a list of some of his strengths, and I just realised that one was not on there, and that is his amazing ability to do impressions of birds in the outback, which he's picked up when he lived out there. And hopefully the bit of video that you saw did include some of that. So some of his strengths include, this is what we identify, the good sense of humour, he's good company, he's well liked by all the staff at the surgery, he likes to help others, he's very knowledgeable about martial arts, he's made a Keep Fit video, which he performs in and narrates, he's an imaginative and creative thinker, he's highly intelligent, he's a hard worker, he's highly skilled hard worker, and a popular fruit picker. He's a loyal person, he doesn't like letting people down, he enjoys visiting the surgery and receiving support, and he has lots of energy. Now, just sitting with Mark and compiling that list showed him a great deal of respect and healthy curiosity on my part, a far cry from the often reported feelings of patients being disempowered, devalued, dehumanized. So we got to a good start. Mark was here in the surgery as a voluntary patient and was clearly showing motivation to change, but on his terms and his terms only. Mark, in his own way, seemed to be responding well to an approach that flattens the hierarchy between the clinician and the patient. This recovery approach, i.e. a greater sense of hope, self-determination, dignity, and ultimately ownership of experiences, appealed to Mark. Indeed, it led the way in forming the Therapeutic Alliance that produced so many tangible benefits for Mark and improving the quality of his life. So in conclusion, I'd like to say that mental health nursing is the best job. It blends both art and science, and the primary tool we use is the therapeutic relationship based on trust and unconditional positive regard. We see mental illness as a social disease as well as a medical one, and I'm very proud to be taking part in this debate tonight. Thank you.
Thank you very much, Alan. That was a very good presentation. We'll now move on to Dr. John Farhole.
Terrific. Good to see you there, Michael, and hello to everyone. The picture painted by Alan Haynesworth about Mark is really a terrific example of why we should never write anyone off, isn't it? Here's someone, homeless, multiple symptoms. From the outside, it looks like a hopeless case, and yet when you look within, there's a whole lot of strength. The evidence of the video is, interesting thing about it is, he changed without medication. Not that everybody can get away with changing without medication, but it does show the power of the rest of life and helps us think about the need for psychological and social interventions. And that's really what I want to focus on in my presentation. So the slide you've got in front of you outlines my little framework for treating psychotic disorders, how to think about treatment. So I think that some of what we're doing in psychotic disorders is trying to manage the illness, both the current symptoms and the enduring vulnerability that people have. And there's both, and social way management can be addressed. Then, in a way, the big ticket for people is social recovery. Life is about getting on in the world. It's not about losing symptoms. So social recovery really is at the heart of trying to help people move on from being lost in symptoms like Mark was. And psychological recovery, or dealing with personal issues, is often a component that sort of mediates between the illness and social recovery. And that's really what I want to focus on now. So, in my view, there are four useful components to personal or psychological recovery. I've clicked the the first slide, or the next slide, just outlines the four components of personal or psychosocial recovery that I'm going to talk about. So the first one is dealing with emotional issues. The second one is understanding what's happened to me, or psychoeducation. The third one is self-management of symptoms and vulnerability. And the fourth one is something that might be a bit different or new to you, which is getting in touch with values. So we'll come to that at the end. So let's first look at dealing with emotional issues. People who are living with a psychotic disorder very validly seek help for emotional issues like feeling down, having trouble with relationships. And often they will seek help for those psychological issues more than they will seek help for persisting psychotic symptoms. And in some studies, those psychological issues have been more important to address as judged by therapists than persisting psychotic symptoms. So I think we need to broaden our mind about targets for psychological treatment. One of them is emotional issues. So if we think about Mark, from the case study that was circulated, now what does that suggest about ways that might be usefully addressed therapeutically? Well, down on the next point, you can see I've mentioned perhaps Mark has some social anxiety, perhaps Mark is troubled by low self-esteem. There may be opportunities for therapeutic work to try to address those. Another really important presenting or issue in the presentation that Alan Haynesworth gave us was that Mark was estranged from his father, and he didn't like that situation. And that there'd been a troubled history of disappearing and family breakup and so on earlier. Now, to speak broadly, if you look at evidence-based treatments for psychosis, the treatment with the greatest evidence is some form of medication. The treatment with the next greatest volume of evidence are family interventions of various sorts. And what a family intervention can do is not just support family members who might be distressed, worried and confused about what's going on, but the reduction of stress and the increase in communication and problem solving that might occur will actually likely reduce relapse rates for the individual themselves. So in this case, Mark isn't having much contact with his father, but he'd like to, so there's a great start to trying to bring them together and to help deal with things that have pushed them apart, like his father not understanding and communication being poor or whatever it might be. Possibly a very worthy intervention. The second component I wanted to comment on was this one that is often called psychoeducation, but I hate the term because psychoeducation sort of generally makes me think of some impersonal relating of symptoms of schizophrenia. These are the symptoms of schizophrenia, or you have a disabling disorder that is relapsing. You'll probably be troubled by it for most of your life. You'll probably have to take medications that have nasty side effects, but they might do you some good in between, etc. The standard information about disorder often doesn't connect with people and often doesn't paint a particularly helpful picture in terms of people looking after themselves. So what I call a personalised understanding of psychosis is what interventions. So I've got on the slide there, for Mark to have a story about what's happened to him, i.e. his life with psychosis, that prompts adaptive action, that helps him do sensible things to look after himself, even if he is relatively insightless. So I've got a little example there that you've probably read by now. And if you look closely, it's got some reference to vulnerability, his tough life. It's got some reference to the fact that stresses make things worse, like voices come when he's stressed. And there's some reference to supports and coping that help, like the contact with the nurse, the casual work that he enjoys. So I'm pointing out here that a vulnerability stress coping framework for psychoeducation is quite a nice one to use, and so you might consider that in working with patients. The third component that I wanted to talk about was the one that some of you would have expected me to talk about, which is the application of CBT to psychosis. Some of you will know that there's actually a specialist area of therapy that is CBT for psychosis. And in a few minutes, I can't really do justice to it, but I can talk to you about some things that people often gloss over when they're starting the CBT for psychosis. Some beginning areas that might be just as helpful as some of the fancier belief modification work. So I think the first step for someone like Mark is to try to understand whether, in fact, he sees his delusional world as any different from the rest of his world. Because if we're trying to help him better understand and better cope with, say, paranoid ideation or crazy delusions, then for him to be able to notice and to be able to describe and step back from the symptom makes a huge difference in having a chance of self-management and about understanding what might exacerbate or ameliorate symptoms. So separating self from symptom is a very useful thing to do, and I've got an example there that you've probably read. The next step, I think, is to understand how does Mark already cope with symptoms if he finds them distressing. All human beings do things to cope if they're distressed by something. If he's distressed by his voices or by paranoia of some sort or some other delusional system, then understanding what he does to cope, labelling it as such, and then extending it by adding your behavioural or cognitive or other strategies is a way to get going that may help him. And all of what I've said is sort of beginning stuff that is generally within the CBT for psychosis framework. But CBT for psychosis does go much beyond that. So the final thing that I wanted to comment on was this notion of getting in touch with values, or perhaps more broadly, getting in touch with what's important in life. So I think the crux of recovery is really finding a place in the world that we can live. All of us are trying to find a place in the world. And people who are as mad as hatters are trying to find a place in the world. And the more resolved they are with their place in the world, the better their symptoms are going to be and the better life they're going to have. So how might we help Mark get in touch with what he actually values in life and then build activities and goals around those? Like we can ask him what's important to him. What does he enjoy doing? What his philosophy is for life? Is he a spiritual person? What's moved him? This might help a conversation that clarifies what he values in life. Another thing we might be doing is observing what seems to be important. And from the case history, we hear that he really enjoys fruit picking. And from the strengths assessment that Alan Haynesworth gave us, we note that he's a loyal person. He values loyalty. He values hard work. He values creativity. These are a basis for talking with him about what he might do in life beyond what he's doing now and helping him move into a better place in the world. And that's really what recovery is about, as I see it.
Well, thank you very much, John. That was a very, very interesting presentation. I'm sure all the attendees really appreciate that presentation. And now we will move on to Professor Alan Rosen.
Thanks, Michael. In a sense, my part is really at bringing some of those aspects that both Alan and John have mentioned together, and it would combine a lot of the elements of the strengths approach, making sure that it is not just working with a dyad, but working with the consumer, with the family, if possible, with the permission of the consumer, of course, and going all the way through interventions to service delivery systems, because all interventions must be contained in a service delivery system, whether you're a sole practitioner or you're a team of a certain defined type, whether it's a crisis team or assertive community team or a rehab team or an acute team or a hospital team. That's merely the vessel or the container. It can be evidence-based because there are certainly service evidence-based service delivery systems, but inside that it's essential to have interventions which are both evidence-based, recovery-oriented, human rights compatible or enabling, and which can be delivered equitably across our Commonwealth, both in urban and rural settings and for Indigenous and for transcultural population. In looking at more at a holistic model that combines some of the elements we've been talking about, we would consider that most forms of intervention would work in two sorts of ways in terms of anthropological time. One form of anthropological time is called the synchronic, which is the present time slice, and in that we need to all get involved in active involvement in care rather than passive sedentary models of care. And also in the present we need to extend the kinship or the equivalent of the kinship network in terms of a caring network. So sometimes we may provide a proxy family while the person seems isolated and is not in touch with their own family. The other dimension of anthropological time is called diachronic, which means the past through that time slice and the present towards the future. And that would include enduring continuity of care and also the idea of making progress through life, the idea of growth from stage to stage in life, which we expect for ourselves, and therefore we should be able to expect for our clientele. And that means helping people through their age-appropriate transitions, whether it's the transition from childhood to adulthood or from adulthood to elderhood, or elderhood to ancestorhood for that matter, but the idea of having some structures which universally we've had in rites of passage, and now we only seem to have in terms of shadows and pseudo-rituals to get people through them, for instance, 21st birthday parties or handing of the car keys over, or the age at which you can drink alcohol and write yourself off. So these are only pseudo-rituals and don't make that much sense. So basically we should be able to represent these things also in terms of our therapeutic approaches. So if you're going to look at integrated holistic care in psychosis in the synchronic time slice, that is the present time slice, and try to bring it together, you would have 4 quadrants. This is a vast oversimplification. The first would be biophysical, the second one would be psychological, the third would be sociological, and the fourth would be cultural. Sorry you don't have the slides, but I'll forge ahead. The first quadrant, if you can imagine it, would be the biophysical, where it's now getting well known in trainings of early psychosis, but this should also apply to all phases of psychosis, that you use the lowest dose technologies possible if you're going to use medication in the biophysical quadrant, that you use low impact environments wherever possible, so you use home-based care as in preference to hospital-based care where possible, amongst familiar people on people's own turf and terms. And if you have to use hospital admission, you try to prefer voluntary admission. And if you have to be in an admission facility, you would prefer an unlocked facility to locked, and you'll find so many more, not just acute units, but subacute units getting more and more, and that becomes a huge problem. And then you would prefer oral medication to injectable medications, and certainly being able to hand over medication for people to take on a voluntary basis rather than having to hold them down to take involuntary medication is far preferable. And that is in every phase of care, not just in early intervention, where you quite often hear those sentiments spoken and where it is being researched. The next quadrant would be the psychological dimension, and I think both Alan and John have attended to many of the issues in this, but I'd point out that that having a care coordinator, not an old-fashioned just brokerage type case manager who sits behind a desk and sends you in various directions, but an active care coordinator who's prepared to go on the journey with you and also to be your coach and pacer and do it on a shoulder-to-shoulder basis in ordinary language rather than in technical language, and to provide supportive counselling, cognitive behavioural therapies, if need be, and if helpful to help you understand what else is available, to get into neurocognitive remediation therapies so that you can then understand the information that's coming your way from psychoeducation or equivalent interventions, although I agree with John about the discomfort with the term. Finding a place for psychosis in your life so that you don't just wear it as a stamp across your forehead, but you again look for the meaning of that experience and say, well, how can I gain lessons for myself out of it, and how can I help others at different stages of recovery to mine? How can I help them through that because I've been through it? And you would also focus on self-esteem and moving people through their developmental life milestones, as we were talking about, in that psychological component, although we are now talking also about that advice, the time trajectory from the past to the future. Now, an example of the psychological quadrant would be therapeutic optimism. And therapeutic optimism is a mindset acknowledging evidence, anticipating far greater possibilities of recovery from an illness than hitherto considered possible. Now, if you're an old guy like me, and it seems, to me familiar that Mark's psychiatric career of 30 years is nearly as long as mine, except I can move into it, and he's moved into it. We both find difficulty moving out of a career. We've workshopped these ideas, but certainly I was brought up in the era of therapeutic pessimism, and that was my toilet training in psychiatry, and it's very hard to break out of it and particularly when there is so much evidence now about hope instilling, about learned optimism like Seligman, about positive psychology, Tony Grant and his colleagues. Hard to realise that therapeutic optimism is just not a point of view. It has an evidence base, it has relevant skills which can be learned, taught and operationalised. And that's valuable for us to know because we can then make it equitably available. So it's just an example of a strength-based intervention which is in that psychological quadrant. I'm now moving to the sociological quadrant, or the sociotherapeutic quadrant. And what we're building is not the biopsychosocial model, because Engel never meant it as a model anyway, it was just an idea, but we're really talking about the biopsychosociocultural dimensions of holistic care. And now we're in the sociological quadrant, where we would talk about retaining or temporarily replacing the social network with a proxy network, again, people who may be at different stages of recovery who can help each other along. Vocational and leisure rehabilitation, because the variance of outcome due to getting a real job, however part-time, for real pay, is as good as any other therapeutic intervention we have in our toolbox. And returning to studies or skill training or work, paid work, is a very important aspect of that. And then what learning we can do as a group, either as a family group or as a social group. And this also reinforces that we are not alone, that we're doing this as a communal endeavour. I'm now moving, as an example of the social, to the idea of woodshedding. We have been publishing on this issue, which was really coined by John Strauss at Yale, the idea of having periods of no apparent improvement while acquiring subtle increments of self-esteem, competence, stamina and social skills. And over that period where things don't seem to be happening, people get put in maintenance streams and they get warehoused and they get shelved, either in the hospital or in community programs. Whereas Strauss, with his very detailed descriptive studies, showed how people can be seeming to do nothing but are really bubbling over underneath, and then if you create the most nurturing of conditions and encouraging of conditions, they will make a discontinuous leap into advancement of their recovery. As long as somebody then notices that they are making this change, because they may not notice themselves and certainly their families may not notice it except as a blip. And if you notice it as a real advance, they may then continue to practice it in the public sphere. There are other concepts too, but I'm running out of time, so I won't deal with them in any detail. I'm now moving to the last quadrant, which is the cultural quadrant. And there's the microculture of working with the family. Mark is a really good example of this. Mark is estranged from his dad presently, but would like to be rejoined, and lost access to his mum somehow when he was age 10. And there's no reason why you shouldn't start doing family work when there's no family around. You can start doing family work with people's memory of their families or conversations they'd like to have with their families. And so you can have do family work with a person who is isolated to start with, and then maybe that will lead to bridging towards doing real family work rather than having just a sudden transition to doing that. And on the other hand, you can also start working with families who have no patient, who have no identified client. The person that they have lost has not come back to them yet and may have suicide, so may not be there. But the issue is that you can do family work with a missing member, and remember, it can happen at both ends, and it's fruitful to do that, to bridge between families and the individual they've lost, or the other way around. At the macro level, the macro culture of dealing with society and society's stereotypes, you're working with stigma and discrimination. and you then start thinking of recovery of your place in the community as a full citizen. And that is part of the cultural entitlement, full citizenship. Just to end, we look at the longitudinal past, present, future dimension again, and in that dimension you would start with looking at the more acute stream and hope that you have more filters than just going from an acute outpatient service straight into an inpatient service. As in New Zealand presently, and as in many places in the UK, after crisis intervention, you should first of all have a crisis team that works on a 7-day-a-night basis, and there are fewer and fewer of those left in Australia who work around the clock and are available to families where they live at any time. But after that, you should have some choices, and some of those choices, if you were in, say, Wellington, New Zealand at the moment, you would be able to go to a respite home, and you could go to a highly staffed or a lowly staffed one, depending on how the severity of your needs. And you would also then have a home delivery, a home care team who could move into your home and special you in your home rather than just only being able to be specialed in hospital. We're up to the beyond the cultural slide now, if you can move it on, Michael, to the continuum of care, the last two slides.
I'm sorry, we're having intermittent problems with the slides. I'll attempt to keep up with you as best I can.
Trying to catch you up. But you need those filters in place before you get to emergency departments, and then you need to be able to move people on through continuity of care, care coordination, which could happen both in the public space or in the fee-for-service space. But I think the important thing about that continuity of care dimension is to make sure that even if you're in the fee-for-service space, that you'd be able to form de facto teams so that people can provide all those elements that we need in the care of psychosis, all those evidence-based and human rights-oriented interventions and service delivery systems that we have talked about. So the rest of that continuum goes to assertive community treatment teams if you need added intensity, which provide you with people who can work with a low number of clientele each, but they can provide a 7-day-a-night service to prevent people having to go back on a revolving door basis into hospital over and over again, and also provide all those quadrants of care at the same time and earn trust by developing that glue of history that good care coordination can provide if you have time to do it. Then you need sometimes residential facilities of a low level of supervision and some with high level of supervision, and you should be able to think of those before you land in medium to long-term inpatient rehabilitation. Again, you should have that range. If you don't have range, you don't have choice. And what we're talking about is if we're talking about individual needs, individual care plans, and to be able to involve people in having a choice between what their needs are at different levels of intensity, you have to have range. I think we'll leave it there.
Thank you very much, Alan. I've certainly learned a lot from listening to the three of you present tonight, and I'm sure our attendees are experiencing the same. There are many questions coming through, but this next phase of the webinar is where each member of the panel will get to ask the other two one question. And we will start off with Alan Haynesworth, who's going to ask John Farhall a question.
Hi, John.
Hey, Alan.
Still there?
Yeah, I'm still here.
Good.
I can see you.
I'm good, yeah. This has been really, really interesting so far. Let's hope it keeps going that way. My question to you, after 12 months of working with Mark, I had the option of transferring this role under better access to a private psychologist. paid for by Medicare. Do you think it would have been easy to achieve this? I ask this as we've recently been informed that the government, after a review, have reduced the number of sessions you can now claim under this scheme, partly as a result of finding that the scheme was targeting high prevalence disorders at the expense of the more severely unwell.
Okay, well, good question with a few bits to it. I guess if we're thinking about better access, it was designed to treat anxiety disorders and depressive disorders primarily because they were seen to be ones that were particularly underserviced in the system we had in Australia. So Mark would not be a typical person and not a person for whom that system was set up to serve. But we can think about what might be possible for Mark, and most listeners will be aware that the federal government is going to change the maximum number of sessions available under Better Access from a potential maximum of 18 per year to a maximum of 10 per year, which makes a very big difference. So what might you be able to do with Mark in 10 sessions? Well, you might be able to do, or at least have a go at, some time-limited focused psychological services, if you want to put it in that language. If Mark was seen to be at risk of relapse, then remember that he has got some persisting, perhaps a chronic level of psychotic symptoms. I'm not clear to what extent he's up and down with those. But he's at risk for getting worse, perhaps, if he doesn't have protection of medication. So you might do some sort of evidence-based relapse prevention program, which you might realistically be able to do in 10 sessions. In terms of more formal CBT for psychosis, typically those treatments are sort of 15 to 24 sessions. So you could have a go at it in 10 sessions with someone who's got the length of history of Mark. If you think about how central a part of his life his delusional world is, then you've got to be realistic about what you might change in 10 sessions of contact. You might be able to ease it, you might be able to add to coping strategies. It may be worth a go, but it's a shortish time for that. The individualised, personalised psychoeducation, you might be able to do that in a more focused way with 10 sessions. So I think within that framework there potentially could be services that would be compensable under Better Access that would be worth a go. Would Mark engage with those? I don't know. You probably got a better guess about that.
That's always a moot point, isn't it, John?
Yeah.
Are there any questions you'd like to ask Alan?
Oh yeah,
Alan Haynesworth.
Well, I'd like to ask both the Allens, but I'll start with Alan Haynesworth. I guess just sort of on this theme of number of sessions. You had the luxury of a year or more of regular contact with Mark. Can you give us a perspective on what time seemed to be required for some of the changes we saw in Mark to occur? Were things happening in 5 or 10 contacts, or was it 5 or 10 months before things were happening? Well, what speed do those terrific changes occur in someone with as chronic a history as Mark? What's the time frame then?
5 to 10 seconds, to be honest. You can make such an impact with someone like Mark within the blink of an eye. It's people like Mark come into, whether it's doctor's surgeries or community mental health centres or whatever, and they're very, very hyper-vigilant to criticism and they're very suspicious and paranoid people, and they're very, very, they can see through things very, very quickly. And so many patients describe the way they felt when a receptionist, for instance, didn't treat them well, didn't respect them very well, and they didn't want to come back. They didn't even want to go any further than a receptionist. So I just want to make that point about how instant your attitude is picked up by people like Mark, and how you can either win or lose the whole game there right from the word go. But in terms of the work subsequent to that, it took ages really, and it took months before, before he would accept me referring him on, which I did to what we called a FAMS worker, which is a personal helper and mentor. Before he would, because he was pretty paranoid about me, he believed that I was a spy for a long time, and probably still does, to be honest. But it took me a few months before I could kind of safely refer him on to the FAMS worker, which I did, and it was pretty successful as well, even though he did believe right throughout his work with the FAMS worker that he was an ASIO operative. So you're right, I did have the luxury of building up a rapport with Mark using all different informal and formal styles, and it took months, and I saw him pretty much weekly for ages. I mean, it was a luxury for me and Mark that to develop.
Yes, that's very good. Thank you, Alan. While we have you there, Alan, can you just stay on your microphone there? I might just ask Alan Rosen to ask a question of Alan Haynesworth. So we have our psychiatrist asking our mental health nurse a question now.
Mine's a flurry of questions about the systems issues in Mark being handed on or being discharged from various services. And Alan, I was curious and I think somewhat concerned about Mark being discharged from care by the public service, and then after that wonderful chapter of work that you did with him about then being passed on to a FAMS worker, but without any integrated clinical interface. I would have thought, in fact, we might have wanted to increase the intensity of what was being offered, but with similar provisions as you had started, like proper respectful engagement and working on strengths in a refreshing way, etc. So I'm concerned that even while he was in obvious need and he was still deluded, but because he didn't want any services, he was discharged from the public system. What was the quality of his judgment when he made this call? I mean, maybe that's part of his psychopathology or problem, that he's rejecting all clinical care. And what is our duty of care to people with poor insight who are not dangerous yet? Do you have to be dangerous to get services? Should we discriminate against non-dangerous clientele by depriving them of a recovery service? What is the balance in human rights terms between the right of refusal or to exit services versus the risk of what Daryl Treffert used to call dying with your rights on?
Mm. It's very hit and miss, I think, the mental health system, isn't it? Because I've known patients to be scheduled and taken in on the grounds that they were a risk to their reputation. So it runs hot and cold. It's hard to understand how it works at times. But with Mark and his relationship with that sector, I think partly it was because he's a placid guy. He's non-demanding and he's displaced from his family and he has no friends and he has no advocates. And he was not felt to be dangerous or a suicide risk. And he also refused to take medication, which really, he was not a good prospect. And they had no measurements for someone like him because it was very kind of medical-orientated model of care. I used to work in the same team, and the things that got talked about all the time and discussed at the clinical review meetings about compliance to medication and who was taking the depots and who wasn't, and who we should get the police to go round to, and it all got quite macho at times. So I think he was let down for sure, and he made a decision which was definitely rational, I think, because they didn't show much interest in him. They didn't have much curiosity towards him. They did mention to him that we could help you with your housing and your finances and stuff like that, but that never got anywhere. And in the end, he just got fed up of hearing the same stuff, and he was going to them, interestingly, So he was compliant to that point. He was actually going to them and turning up at his appointments. But ultimately he walked because he wasn't getting anything from them.
Was he ever offered, or did the service have an assertive community treatment team with high fidelity criteria?
No, they didn't have, in that area of Sydney, they didn't have an assertive outreach team as such. They do now. I'm not sure how they're getting on.
Well,
he would have been an ideal candidate. But would he have been referred? Because it was, the impression that I get was that the best that they could offer him would be medication, and without medication they couldn't really work with him because that was their expectation. It was a low aspiration that they had for him.
Not the assertive teams I've worked with that will think he would be an ideal candidate.
Yeah.
Gauge so that you might work with the other quadrants, and as you can engage him in seeing the sense in it, maybe then work with the biomedical, but earn your trust by doing all the practical things that he wants done.
Thank you very much, Dave. I think that's been a very good discussion around those points. We'll have to move on. Unfortunately, time is moving on tonight too quickly for such a good discussion. But we might just get Alan to ask Alan Haynesworth to ask Alan Rosen a question around about risk. And of course, some of the attendees have mentioned substances as well. So I might ask you if you could, Alan, in your reply, to just mention substances as well as risk after Alan Haynesworth asked this question.
Hi, Alan.
Hi, Alan.
Hi, thanks for that presentation. It was really good.
Thanks.
My question to you, risk assessment has become a major part of the way people with psychosis are assessed, diagnosed, labelled and subsequently managed.
Yep.
Do you think we've gone too far, resulting in a risk-averse culture? And do you think that there's a bigger role to play for the strength assessment?
Yeah, I think that what we've done is got out of balance. I think the priorities in health have become, and particularly in the state I work, in New South Wales, have become assets management number one, occupational health and safety number two of the client of the staff, not of the clientele and not of the families, but only of the staff, and clinical and functional priorities have become a poor third. I think this has happened in other parts of the Commonwealth as well. And I think the problem is we're not looking for balancing opportunity with risk. If you remember the part of the definition of crisis in those famous Chinese symbols was that crisis contained both opportunity and risk. And therefore we should be thinking in terms of people's acute problems or ongoing severe problems as containing both those elements. So I think really we should be looking for the opportunities through the strengths and through the opportunities for growth in recovery, and as well as not risk, not just trying to contain risk, but managing it in as creative way as possible. The main principle here is you've got to determine what is the evidence-based way of working that works best, which is the best buy. And for instance, if going out and doing a home visit is supported by Cochrane and other evidence-based organisations, then you should be able to work out how you manage risk around the evidence-based good that you're trying to provide, not just become fortress hospital public services, leaving both the fee-for-service people and the families in the community bereft of services in the community because you're so preoccupied with risk of your hospital staff.
Thank you very much.
Thanks, Alan.
Thank you both very much. Now, John Farhall, you have some questions that you'd like to ask Alan Rosen around medication and also around early intervention.
Yeah, so Alan, Do you allow patients of yours who've got, chronic psychotic symptoms, insightless, to refuse medication? And if you do, what do you try and weigh up in making that sort of decision?
Well, it's not a matter of whether I allow them. If they decide that that's what they want to do, and they are in a phase of care where they're developing without requiring medication, I think we need to honour that. I think we've got to remember that the illnesses that we used to think just meant, as was said earlier, just taking your medication for the rest of your life. That's not what is in evidence in terms of the prognosis, for instance, of schizophrenia. That we know a third get better completely, a third have a social recovery, and the excitement is in that last third that seem to have residual symptoms, and from which we can prize, with working with them in the Therapeutic Alliance, usually quite a workable recovery if we work hard at it and engage them well, as Alan and yourself have been mentioning. So I think it's really like the same way as you decide about whether somebody needs admission. It's if you've got schizophrenia, it's not the diagnosis that would get you to hospital, and it's not the diagnosis that will get you the medication. But I think of the five Ds in terms of duration and severity, how much distress that person is going through, how disorganised they are, how much defamily. I couldn't think of a D word for defamily till somebody told me that it was disaffiliation. But how alienated you are from your family, yet you at the same time yearn for a connection. So there are those sorts of issues which would bring you to, I'm danger. Of course, the last D is danger to self and others. So if you can work without those, I don't think it's just simply a matter of danger, and I think that we only count danger as a criterion for whether we insist on medication or treatment is wrong in this country, and it doesn't occur in other countries like the UK, and consequently the death rates from injuring of families and others is lower in those countries. At least that correlation has been made in Nielsen and Company's studies. So I think it's really, and I suppose if you wanted to add a 6D, it's drug and alcohol as comorbidity and other forms of comorbidity, the complexity issues. But I think what we try and do is try and work with those 5 or 6 Ds in voluntary ways, because a lot of those, if you work with those issues, a lot of them do make sense to the person involved and to the families involved. And if you can engage them and help them see the sense in working on some of those, they might not want to work on all of those. You may be able to do without medication, but if they're red lights in most of those compartments, you may need to have to insist on medication. But I think we do too much insisting and not enough engaging.
Now, just to finish, thank you very much, Alan. Just to finish up the panel's questioning of each other, we're now going to ask you, Alan Rosen, to ask John Farhole a question, just to finish off the questioning round.
Well, I just wanted to ask John, from your vantage point and from some of the things you've already started talking about in terms of better access and ATAPs, how could fee-for-service professionals form a de facto interdisciplinary team with specific delegations and repeated consultative reviews around the individual care plan?
Very good question. I can give you a nice political answer, Alan, which is have a Medicare item for consultations and reviews that psychologists can get reimbursed for. Because the current system is one where there is simply one form of fee and one form of reimbursement, which is an office-based consultation with the person.
Yep.
and what you do on top of that, you do in your own time or because you're a good practitioner. So I think, if the government wanted to make a better system out of it, they should think about the range of types of reimbursable activities that you might see in GP practice and think about which of those might be relevant in this better access context. But look, I think practitioners just vary enormously. There's some terrific practitioners out there who go out of their way to liaise with GPs and mental health nurses and social workers and others who are involved with someone or have been involved with someone. And I think collegiate getting together, through the mental health professionals network is likely to encourage that, even if it's not reimbursed. But structurally, I think there's a problem. It's an office-based contact structure, and that doesn't help collaboration between professionals.
Thank you.
Thank you very much. That was very good. Now, we're coming towards the end of our webinar, unfortunately, and I'm just going to ask each of you to just sum up in about 2 or 3 minutes. And I'll actually start with you, Alan Rosen, and we will then go to John, and we'll finish up with Alan Haynesworth.
I feel like I've had enough to say, but I just want to emphasise that when people are in need, we shouldn't make it too easy for them to sack us. So that we should really work hard on engagement. We should really work hard on those interventions and styles of intervention that make people want to engage with us more, and that we don't systematically use, whether in public practice or in fee-for-service practice. And that includes things like living wills when they're far more lucid, to be able to determine what they want to happen in periods when they're not, to have shared care planning and joint decision making, and those technologies have been researched, very well researched, and anything to avoid that overuse of involuntary care that we have habitually in English-speaking countries, not just ours, but ours among them. We overuse care. At the same time, we need to have standards for allowing people to exit services, not just entry, but exit services respectfully when they are no longer in need of them, so that they can go back to the same sort of care that everybody else gets in the community. But we do it on a rigorous basis, and also make it easy to re-enter services. Some of the reasons people stay as chronic outpatient attenders or stayers in services is because they're frightened that they'll be on a waiting list for case management if they have to come back, or on a private practitioner's list, and that it takes too long to get back in again.
Thank you very much, Alan. And John, may I ask you to sum up for 2 minutes?
Yeah, thanks for that, Michael. I'm actually going to cheat. I'm not going to sum up. I'm going to add something. One thing that we haven't touched on that is a pity is the non-government organisation sector here.
Yep.
The fastest growing sector of mental health service delivery in Australia at the moment is non-government services. There's a fantastic, amazing array of non-government services, of residential support, home-based outreach, peer support services, employment services. We know that Mark got some support through the Personal Helpers and Mentors program, which is a terrific program because you don't have to have a diagnosis to get help there, and yet the people who get help through that program are some of the most disabled people with mental health problems you can find. So I think in terms of partnerships at a local area level, we should think beyond the traditional players in primary care, and look to see who the non-government organisations are that are working in the area, and get to know them and to get in touch with them, and have your clients or patients benefit from those sort of services. So that's my plug.
Thank you very much, John. Alan Haynesworth, may I ask you to finish off, and then I will sum up the evening.
Yeah, I'd like to say something about the tragedy that is some of the attitudes in that mental health system that we talked about, and how some of them professionals are missing out on some of the fun that we get from caring for people like Mark. And Mark's got a great sense of humour, and so have I think. And I sat down with him one day and I said, you know what, Mark, I've just written down there that we've done reminiscence therapy today. I'm such an advanced practitioner, aren't I? We've done reminiscence therapy today, and all that was allowing him to watch some YouTube videos with me of some 1970s rock bands that he's into. So it's not kind of like technical and scientific at times, and it's really interesting and good fun work. And yet, I don't know, they're missing out, aren't they? Wherever I've worked, there always is an issue with the local crisis team or the local mental health services who don't appear to be very sensitive or accessible or easy to work with, that they have an aloofness and a kind of superiority attitude, and their language as well about everyone's a PD, or non-compliant or whatever it is. And we need to break that, and there's something we need to do. There's a big, massive job ahead of us there to break down that and to make them part of the rest of us,
Thank you very much, Alan.
Therapeutic optimism, that's it.
Yes.
Thank you.
And that's what I'm hearing tonight. I think it's in mental health, as Alan mentioned earlier, you come into it with a feeling, if you are of an age, as Alan, Rosen and I are, you have come into medicine in an area when there wasn't much help, and it was very much medication oriented. And what I'm hearing tonight is holistic care, the art as well as the science, and the use of evidence-based approaches, therapeutic optimism, family involvement, the use of cultural milestones, and the sociological approach to patient care, combined with an understanding of the person's psychological state at the moment in time that you're attending them, and attending to their inner world, and trying to make sense of what their inner world is like. And I feel quite humble attending this webinar, and in spite of the technical issues that we've had, we will all be able to, at any time in the future, but certainly within the next 24 hours, access this webinar. A recording of the webinar has been made, and it will have clear and good sound. I am going to ask you all just to say goodbye to each other, and I look forward to meeting you all at some stage down the track, and also probably having you back again on MHPN.
Thank you, Michael.
Thank you,
Thanks for that, Michael.
Okay, and don't forget, attendees, to attend to your exit requirements for your CPD and to your feedback to MHPN. And also, may I ask each presenter to click on the exit button in the top right-hand corner.
Thanks for everybody for being there. Thank you.
Yeah, good night, everyone.
Good night.
Thank you, everybody. Good night, everybody.